Hey guys, recently Darby and myself sat down with John Littleton to tell you a bit about him before listening to the podcast. Here's a brief bio. He's an organisational psychologist with a graduate diploma of applied psychology and a Bachelor of Psychology and Sociology. John is a senior organisational and consulting psychologist with over 25 years of experience, including 12 years working with complex return to work cases. Throughout his career, John has successfully treated patients suffering from conditions such as anxiety, chronic pain, PTSD, bipolar disorder, low self-esteem, grief and loss, and anger management through a combination of cognitive behavioural and acceptance commitment therapies. He is a founding director of Long Tail Resolutions and brings his considerable skills as an outstanding trainer to the effective management of complex return to work cases. This knowledge has enabled him to work effectively in a range of operational environments in both the government and corporate sectors, delivering results in improved organisational outcomes. Take it away, man.
Great. National Conference for Osteopathy 2016. We'd like to welcome John Littleton.
Thank you very much.
John, can you tell us a little bit about what you're presenting today?
Good question. Where's the title? No, I'm kidding. It's on really about, true for all allied health professionals, but when you're interacting with a person, a client, customer, patient, whatever you want to call them, that how we don't take on their problems, how we don't let ourselves get distressed or upset by what's going on, because they come in with stories, pain stories, injury stories, being badly treated stories, and they often want to talk to you about it.
Yeah.
And there's a risk not only in that, but there's also the risk in your treatment as you're interacting. Their expectations about whether you're going to cure them, whether you're going to get rid of their pain. They don't just bring their injury in, they bring themselves in, and there's a transference that goes on between any allied health professional and the patient that can build up over time and affect the practitioner's functionality and expertise and coping.
I'm sure there's many factors that lead up to this, but is there the power imbalance?
Well, there always is, and some of them will be very reactive to that. So some of them will come in very defensive. Unconsciously, and this is probably my area of expertise, unconsciously projecting onto the person, well, you're not injured, and you've got a job, and you're doing okay, and I'm in this hole, surrounded by a lot of excrement of what's happened to them, and they're basically angry. And they'll sometimes even come in with that. Or they'll play victim. Poor me, and they'll amplify the pain levels. Or they'll be in a defensive mode. So what they'll do is they'll be scared to improve because improvement might mean has consequences in their mind. And you're sitting there naively going, well, I'm just going to work on you and then get you better and whatever. And they're playing all these games with you, mostly unknowing themselves, sometimes quite known. And that builds up frustration for the practitioner and things like that. So,
I was chatting with someone earlier, and this just reminded me, she's a rural osteopath, and she says that the one thing that she really loves is working with farmers. They have to get back to work. You're going to treat them and do the best job you can. The one thing she finds very challenging is working with people who come to her on work cover.
Yes.
Because they're suddenly given a license to not necessarily or unconsciously not get better.
If there's a lawyer involved, the moment you hear the word lawyer, you know it's going to be difficult. And I remember talking to a surgeon, and we were talking about a rotator cuff tear, and he said, and I was asking how long do you think it'll take for him after the rotator cuff tear repair to be able to be functional enough to start going back to work? And I said, about 6 weeks. And he said, is this work cover? I said, yeah. And he said, 12. That's from many years of experience.
And it's becoming that transparent, or it has been.
Well, the research is there. They call them in rehab or work cover long tail claims, where the immediate group of people peter off. The number of injured workers still out of work after an injury in work cover, it peters off very quickly. It gets down to a small number, but about 12 weeks. If they're still injured and still incapacitated, then there's something like 70 to 80% chance that it will be a long tail claim. That is, it'll extend well beyond 6 months. So, and that's part of the conditioning of work cover itself,
Yeah.
which teaches people to be victims. Sadly, and I don't care who's hearing this, but
Yeah.
it's an abusive system. It's
Yeah.
litigious by definition. They didn't give work cover to insurance companies because insurance companies have a reputation for doling out money. They gave it to them because they didn't want them to dole out money. So there's immediately an opposition, and people immediately are disempowered. And I don't know if osteos get much of this, but OC Rehab has had for years something called the flag system. So red flags, yellow flags, black flags and blue flags.
Oh, okay.
So red flags are medical conditions that haven't been recognised.
Yeah.
Yellow flags are the psychosocial ones.
Yeah.
Blue flags are the work-related stuff about how the employer treated them. And black flags are systemic or guideline flags, so rules and regulations that actually inhibit. And it's literally a checklist you go through, working out, from the moment they come into treatment, where are they? And if you get a number of flags coming up, then you've got, it's designed to say high risk of long, protracted return to work process, if ever.
And is your focus primarily on the blue flags?
As a psychologist, my focus is on yellow primarily as the psychosocial, to a limited degree on blue, because as a psychologist in private practice, getting work cover referrals, returning to work is primary. That's what we're mandated to do. But we can't do a lot with the employer because we're not there to do a lot. But the latest work cover plan that you write, which goes to work cover, asks, have you talked to the doctor? Have you talked to allied health? Are they allied health treaters? Have you talked to the employer? So there's an impingement or a desire that any treating practitioner in that system will be negotiating and talking to other practitioners and other stakeholders to try and improve that process of getting people back to work.
Do you work in close alliance with and in referral with other allied health practitioners like osteopaths?
Well, I can answer that in two ways. I've worked for many years in OC Rehab, initially as a case manager or rehab consultant, managing the case, but then got out of that as fast as I could. And have worked, but still worked with a couple of rehab providers in terms of providing psychological intervention, like medical fitness for duties, psych functionals, and treatment. And at the moment, I'm working with young Terry Stewart, who's an osteo in New South Wales, and he and an exercise physiologist, Heidi, we're setting up a pain program. Looking at, we had a bit of involvement with Pain Australia, and I'm going to provide the psychological component, and they'll provide more of the physical. But we're doing it as the latest language is not multidisciplinary, but interdisciplinary. So the difference in multidisciplinary is that, you're going to go off and see the osteo, now you're going to go off and see the physio, now you're going to go off and see the psychologist. Whereas interdisciplinary is all those practitioners, including the doctor, all talk to each other. So you do it as a team with the patient or client, rather than as individuals sitting separately in their own little spaces. You're
doing that because you see value in an interdisciplinary approach?
Well, it's part of best practice. It's basically, they're saying best practice is the biopsychosocial model of pain treatment, and a team of allied health professionals and health professionals talking to each other about what we experience. Because one of the problems psychologists have is they sit in a room with a client, and basically they talk to this person, and if that's all they talk to, then they're only left with that piece of information. Of course, that can be incredibly biased at times and distorted. So if anything, OC Rehab's taught me you talk to everybody. Because what you see is not what you're going to get necessarily. It's not that every patient or client is biased. Is deliberately manipulating. Some certainly are, but they're still looking at it through the lens of their own experience. And while that's very valuable and primary, it's not the only lens that exists. And to be thoroughly professional, you need to be able to look at it from multiple lenses.
And I imagine, from what we've heard in a few of the other presenters, is working in that interdisciplinary areas mean that you get that perspective. You get to see that, well, maybe they are feeling vulnerable in their mental health states, and I'm not noticing it because I'm not asking.
Well, they come in and they perform a role to you. And sometimes they're very deliberately painting a picture. Sometimes They're just reacting to you, and your personality will have an impact on them. And so you want to be able to hear other things and then come back to them in the room and present that to them gently but firmly, and ask them what they understand and get them to explain what's going on, and then work from there. So absolutely.
Yesterday I was having a conversation with someone talking about, as young students, manual therapy, science, it's all where it's at for us. We're rote learning a lot and not necessarily getting hands-on just yet because we're young. And the part that I keep coming back to is that true professionals out there, the people that are presenting here as well as osteopaths, are saying that manual therapy is one attribute of what we do. The psychological aspect, the supportive, the nurturing, the rehabilitative, the sport and exercise. As osteopaths, we're great at doing that. But we also have limits within the amount of, psychotherapy or psychiatry that we can offer. Yeah. What are some things as young clinicians that we can do to help, I guess, not only address mental illness and our perceptions of, but also then help refer clients, say in the case of chronic pain, to say, seeing a psychiatrist doesn't mean you're mad.
No,
it just means...
Nor a psychologist.
Psychologist, No,
that's all right. The psychiatrists get the mad ones. We just get the ones that are struggling. Or mad. Depends what label you want to throw at them. Look, that's a great question, because there is so much of the interpersonal that goes on. And the other alternative I was trying to present to these guys, the conference that I'd like to have presented on, was motivating people to take on the task, because all good therapists, I think, don't simply... I think the average... I always talk about three levels of clinicians. There's the good one, the good, the bad, and the ugly. The good ones teach people skills, help them educate on what to do, and then send them out to do homework, which is literally take this home, do it. That's how you get best outcome. The benign ones, if I was to use an osteo-type model, will simply just massage, make them feel better in the room, and then send them off and say, come back. And they may love it. They'll come out and say, got a great osteo. I go in there feeling sore, I come out feeling a lot better. But I'm now dependent on him because he's the only person, or she's the only person, that can make me feel any better. And psychologists do the same thing. We call it sort of Carl Rogerian reflective listening. How are you feeling about that? And that's the whole session. And they walk out feeling great because someone's listening to them. That's brilliant. But then the problem hasn't resolved itself. They're still doing the same things they were doing before. And then you've got the toxic ones, or what I call the ugly ones, who are the ones that actually do damage. They don't know what they're doing. They think they're better than what they are. They're arrogant, narcissistic sometimes, and are really keen to make a profit rather than actually help the person. So they can actually do damage. Fortunately, there's not too many of those, but they are out there. So from that perspective, working, what can we learn? What can we take into that room? My old joke is that if you've got a work cover claim, even if it's a physical one, if you've been in work cover for more than 6 months, you have a mental health problem as well, simply by being in the system. So, it's that sort of process of it and physical pain does that as well. I was listening, and if you can listen, it was on Radio National, and it was the guy who wrote, and I can't think of his name, he slips out of my head, who wrote The Brain That Changes.
The neuroplasticity.
Yes, and he's written a second book called The Brain That Heals Itself. And he was actually talking about pain and how the brain works, and in what he calls competitive plasticity, which is the idea that, he said, when they do MRI scan, this was he was telling you about a pain surgeon or a pain physician who had chronic pain. And he said, when they did an MRI of a brain without pain, those pain areas are very quiet. When you get someone with acute pain, it's like little stars flashing on and off. When you get someone in chronic pain, it's like supernovas in these 14 different areas of the brain that are involved with pain. And he was this surgeon was reading about neuroplasticity and discovered that in the brain there are overlapping areas between physical pain registration and visualization, because visualization, which happens in the occipital lobe, actually then uses another 34 areas to collect data to create the visualization. So there's overlap. And what happens with physical pain is that as the brain becomes more pain focused, it starts to consume other areas of the brain that are used for other things. So, a bit like the amputee and the phantom limb syndrome, it starts to consume other areas, and the brain does this all the time. And so this guy started to do this visualization. Whenever he started to feel pain, and he'd had every pain medication under the sun and been to many allied health and alternative therapies for pain, nothing had really fixed the problem. So he started doing this visualization, and he just used the MRI scans to visualize going from supernovas to a quiet brain. A few weeks in, he started to notice he'd have a few seconds to a minute of no pain. And this is a guy who was in chronic high-level pain all the time. At 12-month mark, he had no pain, was off all medication. So he was using, it's in the book, I think Doddy or whatever his name is. Anyway, was describing this pain physician using his brain to claim back the areas of the brain that have been stolen. It's a bit like ISIS in Iraq at the moment with Mosul. They're just trying to, and your brain's training your brain to claim back. So as osteos walking into with a client, and if the client doesn't have to have a mental health condition, but if they are depressed, if they are anxious, if they are angry, there is a clear correlation between pain registration of pain, that sort of visual analog scale that is commonly used in pain measurement, and mental health related problems, even if it's not clinically diagnosed, just being depressed, being anxious, being stressed, being angry, will actually amplify that pain. And being badly treated is one of the key drivers for pain, what they call pain-focused behaviour, or even there's some talk about chronic pain syndrome as a contributing factor to it, is the way they're treated by other people, especially employees, things like that, as to how pain-focused they become. So from your perspective, one of the first things that I talk to all allied health, OTs, physios, exercise physiologists, first step always has to be building rapport and creating a safe place for someone to talk and express. And, sometimes it takes 10, 20 minutes in the first session or two of just listening more than doing to build that rapport to make everything else so much easier. If you've got if you haven't got someone comes in, come on, let's get into it, I'm gung-ho, fine. But if you get someone coming in, they're a bit pain-focused, they're playing victim, in the sense that they're really doing what we call external locus of control, which is the world has to do something for me so I can change, then that's counterproductive to what you want. So spending some time building rapport. And if you don't get that, the patient or client will say two things to you to tell you haven't got rapport. The first is, yeah, but. Okay, so if you hear a client saying, you explain something you need, yeah, but, that's the warning signs. They're saying, you haven't listened to me, so I'm not going to listen to you. And the second one is, I know, which is that sort of immediate cut you off, I know, which is, again, I don't want to know. So if you get those two responses or anything like that, it means rapport hasn't been built and you need to go back to square one before you touch them and move, or as you're doing some basic massage, and just have a conversation and get their history and understand what's going on, so that they then get the feeling, well, you're on their side. And my line in therapy is often, psychologist is, well, look, I'm going to walk beside you for a little while on your journey, and the first thing I want to do is see what you see. So I want to see your vista, what it looks like for you. And once I get that, and as I walk with you, I'm going to share some ideas that you might try in changing how you experience life and going from there. That's always your first port of call. Second port of call is always experiential learning for me. And that's hard it's not the first natural response psychologists have, because so much of it's in the head. Very little of it is experiential. So I don't know what it's like for osteos, but I imagine it could be done easier. And that is to demonstrate in a way they can go, oh yeah, that was different. Then, so, when I do training, it's usually, what's the problem? What's the solution? And here's the technique. And I think that's a good model for engaging with people. Build rapport, identify the problem, understand the problem, show that you know what the problem is. Then give them a theoretical understanding of what the solution is going to be, and then give them the experiential learning, so they can do things and go, yeah, that was different. And then you can build on that. That builds motivation. To them.
See that experience and it's working for me.
Yes, so but you got to be able to understand their problem from their perspective. And whilst the risk for many experienced practitioners have heard it all before. You still got to stop and go, okay, so this is what's going on for you. And so when I'm teaching people building positive rapport, I talk about reflective listening as the easiest technique to learn, to actually get a clear understanding of what's going on for the person, so they get that you get it.
And that's just verbally repeating what they say.
Exactly. So what you're saying is, it's about verbally repeating what they say. Is that right?
Yes.
And that's reflective listening.
Yeah.
So it's just, but it's hard for non-psychologists because we're not used to doing that.
Yeah.
We'll ask a question, we'll give a solution, we'll give advice. It's very hard to stop and say, and so it's easy to start with, so what you're saying is. So you're saying is it this? Is that what you're saying? And if you're not sure, you always finish it with, is that right?
Yeah.
Just to say, have I got it? And once you start getting, and that gives a yes response. When you get a yes response, Socrates used to use it, called Socrates' yes response. And the more yeses you get out of a person, the more they're going, oh, he gets it. Yes, we're agreeing with each other. Therefore, he must be okay or she must be okay.
Yeah.
Therefore, here's my companion on the journey.
We're allies here.
Exactly.
Yeah.
Which is what you immediately need. So, does that answer? So, did I answer the question?
In the most thorough,
I tend to do that.
expansive way. Yes. I've just discovered TED Talks. Not just, but they're pretty big and front and centre in my life. And
Good. Yeah, there's a lot in there.
Oh.
I'll give you a name of someone to go listen to.
Yeah, who's that?
Her name is Brene Brown.
Yes.
You've seen on vulnerability.
Oh.
Yeah.
I've seen that one too.
Yeah.
Yeah.
Well, I recommend it to most of my clients.
Yeah.
Because part of it is the latest psychological research on positivity and staying positive has less to do with self-worth, which is what we've been believing for years, and has more to do with self-compassion.
It's the softness.
The ability to stand in the presence of your own nakedness and your vulnerabilities and say, that's okay. Which doesn't lead you to blithe apathy of, well, then if it doesn't matter, I don't have to do anything. It actually reverses engineers the process to go, well, if I am okay, then I really want to do better than this.
To be your own personal best coach. Rather
than trying to get lots of positive feedback from other people to make you feel better by doing what you're good at and hiding what you're not good at. Self-compassion more tends to have empathy turned inwards. And then say, you know, what if we assume for a moment that regardless of what you looked like or what you sounded like or what your skill sets were or your flaws and vulnerabilities, if we just assumed you're okay, what would that be like?
Yeah.
And then if you then go from there to self-improvement, it's self-improvement because you value yourself enough to do that rather than I have to do that to look good, to get my self-worth up. So it's very powerful. So vulnerability is part of that, and Brene talks a lot about that concept, but there's a lot of data coming out of the positive psychology field and talking about self-compassion is a very powerful tool.
We were having a discussion earlier about the idea, the thing about Brene Brown that I really like, and I think that a lot of people find her endearing, is that she speaks so much from personal reference.
Yes.
And you know, it's not as though she says she survived the storm of self-doubt. She's still in the storm, working on it. And I think it allows people to empathise.
Well, young lad, let me tell you, at the tender age of 56, I'm still sitting there going, crap, I got a lot of work to do. So I don't know if that's going to make you feel worse or better about yourself, but, you know.
How important is it for clinical professionals to be able to share?
Oh, absolutely.
Yeah.
That was, you know, one of my key treatment modalities is acceptance commitment therapy. And a lot of that is saying, you know, I'm on a journey, you're on a journey, we're just going to share a bit of the journey together. I have some stuff that I want to share with you, but still we're walking together. So it's much more a companion thing than a sort of clinician and patient model.
Yeah.
I have to tell you one quick joke. It wasn't a joke, it was dead true. I rang a doctor one day, and normally when I'm talking to a doctor, I'll say patient. But for whatever this day, I just said, client. And this snooty doctor said to me, only prostitutes and lawyers have clients. I have patients. Oh, okay. And I was talking to a friend of mine who's a psychologist but used to be a barrister, and he's really sharp-witted, and he said, well, if I've been talking to him, I said, well, it's clear that you're not a lawyer. And I thought, fine. Wish I thought of that. Why can't I think like that? That's why I'm not a barrister.
Retrospective.
Oh,
yeah. One woman I've been listening to on YouTube, her name's Caroline McHugh. She does a lot of... She's a strong Scottish accent. She does a lot of professional development, and I think with high-end business, I'm not sure. She talks about the art of being yourself and unpacks this self-perception and the need for being liked. She talks about the idea that we are not what we do, and we are not our jobs.
Yes.
So in this context, what's the correlation between helping people? You were speaking about yellow flags, blue flags.
Yeah.
If we are not what we do and we cannot put our identity to that. If someone is trapped within, say, a work cover, they don't want to go back to work.
Yep.
But they don't necessarily have great job satisfaction either.
Yes.
It's kind of creating the perfect storm.
It is, absolutely.
It's an existential crisis.
Yeah, and work cover's trying to clamp down on that by limiting the timeframes for claims and very heavily pushing people to get fit for pre-injury so they can cut off their benefits simply because of that problem. So that rather than resolving the underlying problem, they're actually trying this way. And it will never work because they'll always adapt around it. It's like when Comcare took stress and work cover took stress, you couldn't write stress on a medical because it's not a medical disorder. Dr. Peter Cotton, who's big in this area, said, well, it's like pushing a balloon underwater. It'll just pop up somewhere else. And it is. Now it's adjustment disorder, which is a DSM condition. But, it's got another name, but same. Sorry, I was going to say something inappropriate, but I won't. Okay. So the question was basically, remind me.
If we are not, well, it's a big one. How do you defeat existential crisis? How do you? One of the things I learned to do under work cover.
Sorry, I just needed a quick reminder of what I was talking about. One of the reminders under work cover was that when I started working with injured work, especially physical injuries, I don't know where I came from it. I'd like to say I invented it. So this could be my first expose into the bigger wide world of this. But I did something where I had an injured worker. He worked at a harbour as offloading stuff off ships. Young guy, late 20s, gung-ho, married, kid, pretty gung-ho, but a lower back injury. So he was in a lot of pain and wasn't at work. And I just thought, he's claiming to be just really motivated to go back to work, but I'm not getting that. So I did this thing. I just said, I want you to describe every role you have in life. What are the different roles you have? So started with employee, work colleague, wage earner, father, husband, son, gardener, cook, handyman. I read about 25 different roles. And I think part of it came from an idea that our self-worth is based on our roles. It's not just a thing, it's all the different roles we play. We play many different roles. And so I said to him then, before the injury, on a scale of 0 to 10, where 10 out of 10 is the best ever and 0 is nothing, how well did you do those roles pre-injury? And so 8s, 9s, get down to cook 4, golfer 3, musician 5, whatever, 8, but high scores for work-related stuff and a father and a wage earner, all that sort of stuff. And I said, now how much do you value each one of these roles? Where 10 out of 10 is, this is really important to me, and 1 out of 10 is, And so we went through the same thing. And then what I did was multiply how well he did the job by how much he valued it. And that gave you a group score like 72, 78. And then I added all that up, and he ended up with about 852. I said, that's your self-worth. Now what I want you to do is rate how well you do those roles after the injury. And of course, employee 1, work colleague 2, a wage earner 4. A lot of stuff went down. Husband went down. Father went down because he couldn't carry his kid, but he wasn't earning the money for the kid, and et cetera, et cetera. And as we went down, we started to, and we went through, some went up a little bit, but usually where the value of the role wasn't that high, so you didn't get a big jump in figures. Add it all up, I think it was around 312 was his score for self-worth post the injury. So you had 857 versus 312. And basically what we had in that situation was, here's someone who has low self-worth. which is very much tied to his roles, both work and non-work related. But often non-work related roles have a work-related role, because as a father and a husband, I'm not earning the income, I can't do things with my wife I used to, can't pick up my kid, therefore my sense of how well I do that. But the values don't change. And it was getting him to stop and think about self-worth. And then my next point of call with him was, so if you've been told you've got a constant companion who you'll have for the rest of your life probably, and your self-worth is down around your ankles, what is the one, and that makes you feel awful, what is the one thing you can use to rationalise why you're not working and why you're not earning income? And he went, pain. I said, exactly. And so your visual analog scale goes up because your brain's focusing more towards that to justify why you're not working, as a way of an escape route to say, I shouldn't feel this bad, because his pre-injury expectations is you work, you bring money into the family, you do all these things. And so here's that person trapped in that role. And that was my first port of call with him. But the secret then became his values. And so what ACT uses a lot around is focusing on values, because values don't change. And so then what I had to do is take his values. So I went and did a values questionnaire with him. We looked at his core values, a team player, being courageous, being positive and optimistic. And I said, what we want to do is take those values and incorporate them into what you can do now. Now, a classic example of this was several years ago, I was working with long-tail claims. These guys had all been, had a medical certificate saying unfit for work for 10 years. And they were all carrying crutches, and one of the guy, and I had crutches, we'll call him Luigi. Won't mention what cultural background he was, but he was Luigi. And I was doing values, and I got him to stand up, and he stood and he said, I got him to do his homework, write down your values. I gave him a list, and he talked. He said, I want to give my child money. I want to be able to give her money. She needs something, she must have it, and I wanted to have it. And, John, too much pain, cannot do it anymore. I was like, I'm going to kill him. So I just looked at him and said, Luigi, so what you're saying is that you're an ATM. That's all you're good for. You're just a machine that dispenses money. That is the total value of your life. And he got angry. No, I'm Italian. I want my child to go to Rome. I want him to understand the Pope and the history and the art and the culture and the wine and the mafia. No, not the mafia. And, he went on for about a minute, waving his arms around and whatever. And after about a minute, I stopped and said to the rest of the group, can you hang on a second, Luigi? I turned to the rest of the group and said, what did you just see happen there? He went, the pain went out of his face, and he was animated, his arms were flying around, and there was energy in his body. And I said to Luigi, in all honesty, what happened to your pain while you were doing that? He dropped his head and said, I'm not so much pain. I said, thank you for demonstrating the role of values. So ultimately, as a psychologist, what we're doing with pain and injury is saying, if you're focusing on it because it's an excuse for protecting your self-worth, if you're focusing on it because you're terrified about going back to work, then what happens is you're feeding and allowing your brain to grow out those pain areas and take more areas of your brain to focus on pain. It becomes very self-fulfilling. So as psychologists, what we're doing, and as any allied health professional, we're wanting to engage them in activities that give them enjoyment, pleasure, because that fires the brain up. We get more dopamine happening in the brain. We get more parts of the brain visualizing and thinking and creating. I mean, here's this guy, after being unfit for 10 years, we discovered under his values that he wanted to write stories for his daughter about Italy and its culture and its history. And so I got his medical certificate from unfit for 10 years to fit for 3 hours a week, so he could do a computer course to learn to write. So, but then going back into the black flags, the insurer, I won't mention who it was, but it was Allianz, basically turned around and said, no, let's give him a payout. And he went unfit again. And when they came to me and said, why is he unfit? I said, well, because you paid him out. And I remember the two case managers from the insurance company looking at each other, giving each other filthy looks as if to say, you did that. And I'm going,
you pressed okay.
Yeah. So anyway, but that's what I mean. And he was prepared to engage in life, and that's what we're getting them to do, is engage in life. So it's about saying you're distracted by your pain. What we want you to do is be distracted by life. And values are a powerful way of getting people to actually engage in life, because we all have a set of values. You're doing your job because you have a set of values.
What if our job diminishes our values? What if the wear and tear of life?
Well, there's two simple answers. Do your values outside of work? If there is something inside of work that you want, i.e. a value that's important to you, or you love the money, fine, do your values outside of work. And there's no people who do that. People work in factory jobs where there really isn't much. So the weekends and the evenings they're out sailing.
They live large then.
So work to live rather than live to work. For many of us in our position, we're privileged enough to say, well, I have a set of values that actually I can operationalise inside of work. And basically, we should do that. If you're not, then my view is get out of that job. You know, go do something that you're actually passionate about.
Don't be trapped.
Don't be trapped, because you get, I mean, it's an existential question, but you get one life, as far as we know. What are you going to do?
We don't get more than one.
Well, that's up to you. The area of psychology doesn't speak directly. The only way psychology speaks to that idea is that it's quite possible that evolutionary psychology says we invented God to deal with the things we couldn't take care of, like earthquakes and famines, and so therefore we invented God to deal with that. You know, so we have to have control. In psychology, control creates safety. How do you get control? By predictability. So if it's predictable, it's controllable. If it's controllable, then we're safe, and that's the way the human brain works.
Quite simple, really.
Well, it came from a very simple time when we were just trying to survive, you know, to the next day.
Now the complexity is multiplied tenfold.
Indeed, because it's a very complex society we live in.
Yes. One final question.
Sure.
You'll hit the main stage in half an hour or so.
21 minutes.
21 minutes. Can you just guide us through briefly the things you're going to talk about in terms of how, as allied health professionals, we can not take on or not burn out due to the stress of patients?
Sure. I think that's going to be very simple. It's 3 or 4 stages. 1, recognise the early warning signs when you're becoming distressed or upset. And I'll put up a checklist saying these are the warning signs. 2, recognise how your mind, and I'm going to do a bit of experiential learning, which is I'm going to do an activity called the Stroop effect, to show that the mind is constantly interpreting reality. So you don't see reality. Everybody listening to me at the moment, you don't see reality. This guy over here doesn't see reality because he's handing you notes and saying 5 minutes, or whatever it is he's been saying, or get rid of this jerk. I think I saw at one point.
Cut him!
None of us see reality. We're constantly interpreting reality through what's called the unconscious or subconscious mind. And that's its job. Its job is to interpret, so that when you feel something, that's your unconscious mind saying, based on unconscious belief systems, this is what I think is going on. And there's reasons for that which we won't have time for to discuss, about the evolving of the brain and how it dealt with threat and danger through this process. So we all have most of our belief systems, which we have hundreds of thousands, are all very healthy. But mental health is created by stress being applied to a belief system that either isn't healthy or is rigid in the way it operates, which means that no matter what the outcome is, we stick to the same process. And that's where mental health problems come from. All of us have irrational or dysfunctional beliefs. The most classic ones, as I'll put up there, are I must be liked and accepted by everybody who is important to me, or otherwise I'm a complete schmuck. Number 2 is I must be perfect at what I do, or the things that are important to me, otherwise I'm a complete schmuck. And number 3 is life must be fair, and if life isn't fair, then life is a complete schmuck. So putting expletive for schmuck. And our unconscious is constantly doing that. And there are a range of belief systems we carry, some of which are either inflexible and therefore don't adapt, or are just wrong. And when patients or clients push our buttons or step on our buttons accidentally, or we take on their stuff, then we start to exhibit warning signs. And so part of the process, as I'll talk about, is you can deal with it in 2 ways. There are external solutions that you can apply, like fitness, sleep, eating healthy, getting a good night's sleep, things like that. All those sort of basic things. A bit of vitamin D out of the sun's always a good thing, etc., etc. And then there are intrinsic or internal solutions, which are cognitive techniques we can use, so that when we feel ourselves getting upset, we can recognise that the only way you can feel upset is if you agree with whatever they're saying. Not at the conscious level, but the unconscious level. So there's a great quote I'll give there by a guy called Epictetus, who was a 4th century Greek philosopher who was a slave and then became a philosopher somehow. And he said, we're not disturbed so much by the things that happen to us, but rather by the thoughts we have about them. And he was the first cognitive behavioural therapist, but because he wasn't a capitalist, capitalism didn't exist in those days, he became a philosopher rather than making millions. So it's about learning to notice what part we play in that process. So an act, they talk about that as suffering. Pain is what really happens. Okay, both physical and psychological pain is if someone yells at you and calls you, whatever, that's painful. Psychological suffering is what our mind then does with that information. And that's the backstory the brain gives us about, well, they hate us and we're never going to see another client again and they're going to spread the word that we're awful and blah, blah, and our minds start festering and ruminating, and that's where our distress level goes up. So the joke I tell at the end is about suffering is a man dies and goes to hell and the devil welcomes him in and they takes him to a room. On the room it says hell. And he opens the door and everybody's standing up to their bottom lip in raw sewage. And all you can hear people saying is, don't make waves. And so as a final caveat into leaving and going off and giving the presentation, to which I may or may not tell that story, is that when we become psychologically unwell is when bad things happen, but then our mind gets involved and amplifies that distress through what ACT would call suffering, which is our own mind causing us pain and suffering until it gets to our bottom lip, in which case that's when we start developing a mental health problem. So hopefully that answers your question. Waves. So I'll be giving a technique or two about how to manage that distress one starts to feel. As an internal solution to what primarily is an internal problem.
One that can be avoided.
And managed. So early inoculation is best, early intervention is next best, rehabilitation just sucks. So
coming back from the brink.
If they ever do. Sometimes they don't. So.
Wonderful. John, thank you very much for joining us.
Absolute pleasure.
We look forward to hearing it up on stage.
Okay, well, yes. It'll be an edited version of that, probably. Thanks, guys. Appreciate it.
Thank you. Thanks for informing the next generation of osteos.
My pleasure.
Great.
Anytime. Thanks.
Before we wrap up, there are some thanks that need to go out. Friday Hut Studios provided us with the logo design. And for all inquiries, go to their Facebook page, Friday Hut Studios. Secondly, Lexa Student Association. They provided us with equipment and support since the beginning. And thirdly, everyone out there that gives us a like and a listen. Thank you. And until next time, take care.